Hello everyone, my name is Trevor Roberts and my injury lecture will be on shin splints, which is the layman's term for this injury that most of you guys probably know it as. But the more correct term and the one mostly used by the researchers is medial tibial stress syndrome, or MTSS for short, and that's the one that I'm going to use as I go on with this lecture. And so that term kind of just breaks down the cause of the injury best, sums it up best. So there's stress overload to the tibia, and it's along that medial side of the tibia. A lesser common term is a medial tibial traction periostitis. So it still has that medial tibial like the first term, but instead now it has kind of a different cause to it. So instead of stress to the tibia, this second theory is suggesting the pain's coming from periostitis, which periostitis is inflammation of the periosteum. And periosteum is, if you look over here at this picture, it's connective tissue that surrounds bone. And so it also important to note that it has blood vessels and nerves. And so the other word in there, traction, being that muscles are pulling on this periosteum, leading to inflammation, leading to pain. But like I said, authors typically like to go with MTSS because as we go over the causes, there's a lot more evidence for MTSS being the actual cause of shin splints. In terms of location of pain, the number one most reported area, and the one I'm going to focus on, therefore, is the posterior medial tibial border on the middle, or more so the distal 2/3 portion of the tibia, which is a whole mouthful. So this picture here kind of best denotes where that pain is. All right, so again, posterior and medial. So if we look here, down the middle toe would be medial. We go posterior, medial, and then middle, but again, more so the distal 2/3 portion of the tibia. That there is the most commonly reported area of pain. Another area that we won't focus on as much, but also is reported and should be noted, is the anterior lateral aspect of the tibia, which is here on the left side of the picture. So now we've gone more anterior and more lateral. How people describe this pain, it's a soreness that is dull or aching. And what triggers it is basically gradual increase or the initiation of weight-bearing exercise. So someone starts running and they're going to feel this pain once they strike into the ground, right? That mid-stance phase of running, when they're basically putting a lot of force into the ground, it's sending up, and then the tibia is trying to absorb that shock. And we're going to talk about how that kind of causes the pain. And that's basically the time when pain starts occurring. How it's going to subside or just be non-existent is with rest or non-weight bearing exercise. So someone starts running, they're going to start to get shin splints. Some people, though, I will say, there are reports where people say that they can just run past it. So essentially they get shin splints, but then it goes away as they keep running. But some people, it might just occur, and then the only way for that pain to go away is just to completely stop. So when they're not exercising, or if they're performing non-weight bearing exercise, they're typically not going to feel the pain. So the importance of it basically is just how it's occurring with weight bearing exercises, again, primarily like running activities. So that kind of just leads me into who typically gets MTSS. So this is a common overuse injury in those who run and also potentially jump. So who commonly runs a lot? Runners, and then as well as military personnel. So these are what I've seen in the literature as the most frequently reported people having this injury, as well as they're going to be the most common population used within medial tibial stress syndrome studies. However, it's also seen in some team sports like basketball, soccer, and football, because they do a lot of running and jumping as well. But again, not as frequent because these are more stop and go, repeated sprint sports. So whereas running and military personnel, they're running for long distances over long periods of time. And then also to dancers, I saw a little bit of reports primarily with ballet dancers. Another thing to note too is that this is more common in females than males. So if you look down here, there was a meta-analysis that actually pooled 9 prospective studies. So again, our good studies, right? The ones that started out with healthy subjects and then saw who did and who didn't get MTSS. So after pooling all of those 9 studies, they came to the conclusion that females had a significantly higher risk than males, and so a 1.71 to 1 female to male ratio. Reasons as why that might have occurred, or why that does maybe occur, is because females typically have less bone density compared to males, and they're more likely to develop osteoporosis, kind of due to the female athlete triad. Another population that this is also seen more commonly in is obese, or just people who have higher body mass. And the reason for that is essentially because as they're running, doing weight bearing exercises, they're going to exert more force into the ground. So that tibia is going to receive a lot more stress, and which we'll see is why that's typically causing the pain. Before we go over the causes, we need to go over the anatomy of some important muscles for this injury. So we're going to start off with our calf muscles. And you're going to see with the muscles, I'll just go origin, insertion, and then action. So starting off with the gastrocs, so the origin is above the femoral condyles, and then it inserts into the calcaneus, right, our heel bone, via the what we probably know as the Achilles tendon. So it crosses the posterior side of the knee and as well as the ankle, so you get knee flexion and plantar flexion. The soleus, though, it has attachments on the tibia and fibula. I'm going to focus on the tibia. So for the tibia, on the proximal half of the posterior medial shaft of the tibia. And so we'll talk about how the soleus is thought as to be one of the muscles causing this injury. So if the muscle is what is causing the injury, you can think, okay, well, posterior medial, that is where, or one of the aspects to where that pain was coming from. However, it was the distal 2/3 portion or middle, which would be down here. So the soleus origin does have a posterior medial portion on the tibia, but again, it's more proximal. And then in terms of how it inserts, same insertion as the gastrocs, right, with the Achilles tendon, but you only get plantar flexion because it doesn't cross the knee joint. And then I'm going to go and review, you might have heard this euphemism in your anatomy or movement anatomy classes, but the Tom, Dick, and Harry muscles. So these muscles are grouped up, right? T stands for tibialis posterior, the D stands for digitorum and the flexor digitorum longus, and then the H for hallucis and flexor hallucis longus. The reason why these muscles are grouped up is because their insertions are relatively similar, or they are pretty similar. So they're on the posterior and then the medial side of the ankle. So since it being posterior, you get plantar flexion. And since it's on the medial aspect of the ankle joint, you get inversion. But it should be noted that the tibialis posterior and flexor digitorum longus, they originate on the tibia, whereas the flexor hallucis longus originates on the fibula. So for the next two slides, I'm going to more so focus on the tibialis posterior and flexor digitorum longus, since this is a tibia injury. So starting off with the tibialis posterior, if we look at the origin, it's on the proximal half of the tibia and then on the posterior lateral surface of the tibia, which would be very important to note because some of the studies suggest that the tibialis posterior is one of the muscles causing this pain. But if it is caused by the origin of the muscle, it's not even posterior medial, and it's not even on that distal 2/3 portion. It's actually posterior lateral. So important to kind of note that, and we'll talk about that later as we go. Insertion, whole bunch of insertions, right? But just kind of focus on how that the insertion of the tendon is posterior and medial, so you get plantar flexion and inversion. The flexor digitorum longus, if any muscle were to cause this pain, it's the closest one to that actual site of pain. So you can see the origin is the middle half of the posterior medial surface of the tibia. So not kind of where that distal 2/3 portion is, but again, now we're posterior medial and at least down the middle portion. So it's the closest to that area to pain if even the muscle is causing the pain. And then insertion, again, kind of the tendon runs similar, right? Posterior and medial, so you get plantar flexion inversion, and then it also inserts onto the bottom of your toe, so you get flexions of digits 2 through 5. So those were all posterior muscles, but we should touch up on the anterior muscle, the main one being tibialis anterior. So its origin, it is on the lateral condyle, but more importantly, talking about here, the superior 2/3 of the anterior lateral surface of the tibia, which you can see here. And so again, if muscles were to be causing this type of pain, this one would be the culprit for where individuals say they feel it on the anterior lateral side. Insertion, it inserts medially. So if you look at the first metatarsal and the medial cuneiform bone, so since it's also medial to the ankle joint, you also get inversion, but this is an anterior muscle, so instead of plantar flexion, you get dorsiflexion. Then lastly, I just want to talk about the intrinsic foot muscles because they are going to play a large role when we talk about this injury and we talk about rehab and prehab. So I'm not going to talk about obviously every single intrinsic foot muscle. So kind of just summarizing that they originate and insert within the foot. And the whole importance of these muscles is they're going to help maintain and stabilize the medial longitudinal arch, which is down here. So if you're looking at this as a medial view of the foot, this arch here would be the medial longitudinal arch. And this is probably what most of us probably just think of as the arch of the foot. Why is that important? Well, it is very critical for shock absorption and then attenuation of forces transmitted during gait. So we're going to talk about kind of how loss of this arch is going to potentially lead to this shin splints injury. So I'm going to go over the causes. There's going to be two different theories, right? I kind of previewed this in the intro slide. So the first one I'm going to talk about is periostitis theory, which doesn't have as much data to back as compared to the idea of just stress to the tibia. So why I kind of said most authors refer MTSS. But so we're going to start off with periostitis. So this was more of the original theory because it was developed way back in the 1950s. Suggesting that periostitis, again, periostitis being referring to inflammation of the periosteum, is caused by repeated traction, or you can just think pulling, on the periosteum from the following three fibers. So the tibialis posterior, the soleus, and or the flexor digitorum longus. So again, if you kind of just look up here, right, so here's the periosteum, kind of just thinking that there's repeated traction, repeated pulling on it, leading to inflammation. And again, kind of like how I talked about, they do have some nerves, so inflammation to that structure would result in pain. However, when we look at the literature itself, there's limited histological evidence to support the theory. And what I mean is they primarily were using biopsies in these studies, and they also all were retrospective studies, which we know aren't as good as prospective studies, as we've been talking a whole bunch in this class. So you can see here there was two studies that did find just 3, though, patients with periostitis. And so basically they were looking at inflammatory markers within the biopsies. But there was 2 much larger studies with more sample sizes. They did find participants with, so the MTSS patients, they found some with periostitis, but it wasn't to the degree enough where it was statistically significant. So again, there were more people without periostitis than with. So again, not a lot of evidence, and if anything, more evidence against this theory of causing shin splints or the pain for shin splints. But if we're just going to keep going on talking about periostitis in terms of why those 3 muscles, so again, that area of pain we're looking for is the posterior medial border of the 2/3 distal aspect of the tibia. And so researchers kind of thought that potentially the tibialis posterior, soleus, and flexor digitorum longus were those 3 muscles that were being overstressed and causing that tugging. But if we actually look at this came from a source, Brown in 2016. He did basically a cadaver study, and so they identified the origin sites for all 3 of those muscles, the tibialis posterior, soleus, and flexor digitorum longus. And you can kind of see it's pretty much where I just talked about previously, which I got from anatomy textbooks. And then you can see also that there were 2 studies that confirmed the results of this one. So again, just kind of basically saying, yeah, anatomy, the books got it right, the origin sites. But if you notice down here, down here would be that area of pain. So again, None of these muscles really, maybe the flexor digitorum longus is close, but realistically, if we're talking about traction causing this issue, doesn't really seem like those three muscles are causing that. And the reason why maybe this idea came up was there was one study that identified the tibialis posterior near that actual pain region. So again, the posterior medial and then the distal 2/3 portion of the tibia. But it should be noted that there were only 10 cadavers in that study, as well as there's just 3 larger studies that confirm the results of these actually being the origin site. So potentially, maybe that study didn't actually identify the correct muscle, or possibly potentially individuals might just have different origin sites for the muscles. But again, kind of like we talked about, there's not a lot of evidence supporting periostitis. But I also kind of just want to talk about kind of frontal plane and sagittal plane moments as to potentially if muscles being overworked, right, overstressed, actually causing this pain. Kind of look at the frontal plane and sagittal plane as to why that is happening. So besides the origin sites, why would those certain muscles be of concern? So one thing we do know and has been prospectively studied is that higher peak eversion moments and durations during the stance phase, so that part where the foot is on the ground and landing from running, that has been seen to be a risk factor. So we know for sure that that is not a good thing and that is causing MTSS. And so if we kind of look over here, this would be a neutral foot, and then this would be a foot in excessive eversion. So let's talk about this foot in excessive eversion. If you think about it, they're going to put ground, because the eversion is kind of medial, so if they put more force in medially, that ground reaction force, right, is going to be equal and opposing, and it's going to go outside of that ankle joint. And then that's going to result in an external eversion moment. And if you kind of remember how Dr. Lin was talking about external and internal moments, so if you have an external eversion moment, then that means you need an internal inversion moment. So basically that the foot doesn't collapse completely, so you don't have too much eversion, right? And so in terms of when we're talking about planting from running, you need the muscles that invert to eccentrically contract and hold that foot or ankle into place. What muscles do cause inversion? The tibialis posterior and flexor digitorum longus. So that's potentially why people thought that those two muscles potentially are causing pain. And then another one too that also does inversion that we talked about was the tibialis anterior. So people who maybe have that pain, and if it is caused by the muscle, it could be due to inversion, right, and the tibialis anterior being stressed. Versus if we had a more neutral, it's not going to be perfectly up on the ankle joint, but you're not going to have this excessive eversion or inversion. And then I kind of want to talk about the sagittal plane too, again, sticking on to periostitis. So, is one muscle being overstressed and being overworked and causing pain? So let's start with a difference between a heel strike and a forefoot strike. So this is when that person's landing from their running. So typically people who run have a heel strike pattern, but let's talk about both. So with a forefoot strike pattern, also I will say, if you notice that this looks familiar, Dr. Lin, I did steal this from your Knees 561 slide, so thank you for that. But if we look at the forefoot strike, the ground reaction force vector is out in front of the ankle. And so again, kind of talking about external, internal moments. If you have a forefoot strike, that ground reaction force is going to cause an external dorsiflexion moment, meaning you need an internal plantar flexion moment, meaning your plantar flexors need to be eccentrically contracting so we can stabilize that ankle joint. So there's two ways you can think about this, and I don't know which one's correct, right? Because there aren't a lot of prospective studies on this topic. As you can see down here, I only have one retrospective study I could find, which I'll talk about in a second. But I feel like you could make two arguments, right? You could argue that, okay, so you are eccentrically working the plantar flexor. So maybe if you have a forefoot strike, you're overworking those plantar flexor muscles, and then those are they're causing pain. Right? Or you could probably suggest that, well, the people who have a forefoot strike, they're eccentrically working those muscles, and so they're actually strengthening them. So again, you could go either or, but I'm not too sure. I couldn't find any studies between a heel strike and forefoot strike looking at that, prospective ones being. And then if we go over here to a heel strike, right? So the heel strike pattern, now this ground reaction force is behind the ankle joint, meaning there's going to be an external plantar flexion moment. And so then you need an internal dorsiflexion moment, meaning those dorsiflexors, the main one we talked about being the tibialis anterior, has to eccentrically contract. And so again, you could suggest maybe that heel strike is strengthening the tibialis anterior more, or you could suggest that it's stressing the tibialis anterior more. But now let's talk about that one retrospective study that I found. So they found that, so again, retrospective, they looked at healthy versus MTSS subjects, and they reported that the MTSS subjects used a heel strike pattern. Therefore, the heel strike pattern was more likely to cause shin splints. Their hypothesis, remember how I kind of talked about two different ways you could potentially look at it, right? A strengthening aspect or potentially an overstraining aspect. They went with the straining one, so they suggested that these healthy subjects were using a forefoot striking pattern, therefore eccentrically strengthening the calf muscles. So again, though, it's retrospective, so been talking about this a whole bunch in the class, like which came first, the chicken or egg, right? Because we don't know if potentially those MTSS subjects were compensating, right? Because you could argue, let's say that they were forefoot strikers and they overworked, right, their plantar flexor muscles, so they compensated and then went to a striking pattern to basically take stress off of the plantar flexors and put it more on the tibialis anterior. So again, fully don't know since there aren't a lot of prospective studies between strike foot patterns. So now going on to the tibial stress, right, or medial tibial stress syndrome theory, which again, this one has more evidence towards it. So MTSS, due to excessive repetitive tibial bending or loading, has received much more evidence than the previous traction or periostitis theory we've been talking about. And the bending at the tibia occurs where the tibial diaphysis is narrowest. And so that's typically about the middle to distal 2/3 of the tibia, which actually lines up as to where that pain is occurring in individuals with shin splints. And so kind of just to talk about, right, because the whole key there is why I have it italicized, right, excessive and repetitive. So a normal healthy response to running is you would have some micro damage to the bone, then you would have some bone formation repair outweighing bone resorption. So in other words, you're building more bone than you broke down. And so now the bone has become stronger to handle future stressors. And that's the whole concept and idea behind Wolff's Law. MTSS response, on the other hand, I've seen some authors basically say it's pretty similar to tibial stress fractures. So you have excessive damage to the bone, which we're talking about the tibia. So now bone resorption outweighs bone formation or repair. So in other words, you're breaking down more bone than you're putting on, and so now we have tibial stress. So stress to the tibia is becoming weaker and leading to pain. So let's talk about what is potentially causing high and excessive loading of the tibia. So I will say these factors here were found to be prospective risk factors for MTSS, and then I think they potentially are leading to excessive overloading of the tibia, causing it to bend and then causing pain too. So let's start here with an increase in pronation, whether that just be your static stance is excessive pronation or dynamic, so when you're doing a loading activity. So when there's increased pronation, if we look at pronation itself as a review, it's motions along 3 planes. So in the frontal plane, you have eversion. In the horizontal plane, you have abduction. And then in the sagittal plane, you have dorsiflexion. So this is what it looks like in a posterior view. Here's what a normal foot without excessive pronation would look like, or supination, versus here is what an excessive pronation stance would look like. And so you can see with that normal stance here, we have that nice medial longitudinal arch, which is great, again, for absorbing shock. Versus here, when we look at the pronated foot, we've now kind of collapsed and lost that medial longitudinal arch. So therefore, you can kind of think you've lost that ability to absorb as much shock, and so then you have an increase in loading of the tibia. And again, pronation, one of the movements is eversion, so it kind of makes sense as to why both pronation and peak eversion and durations during the stance phase are prospective factors for developing MTSS. Another one we've also talked about, right? Increased body mass or BMI. That one's pretty easy to understand, right? Because as your body mass increases, you're going to have more stress that or more force you're putting into the ground, and then that stress or shock is going to be coming up to the tibia and causing more bending and stress to the tibia, more likely to develop that medial tibial stress syndrome. This one was interesting. They found that people who had prior use of orthotics were a prospective risk factor. And so this is kind of similar to the story that Dr. Lin talked about, right, with those Home Depot people using the belts, right? So they were using the belts all throughout the day while they're working, right? And so they don't have to use their core muscles as much. So when those belts came off, they weren't using the core muscles, and then they ended up hurting their back. So kind of the same concept here. Potentially those who were using the orthotics, they didn't have to really use those intrinsic and extrinsic foot muscles to help maintain their arch. So once they stopped using the orthotics, maybe those muscles aren't as active, they're now weak, and so then that decreases their ability to absorb shock, and so potentially causing, again, excessive loading of the tibia. And then lastly here, a decrease in calf muscle girth. So the whole idea behind that is that the calf muscles, they help reduce shock absorption of the tibia. So if they're smaller and weaker, then there's potentially more tibial loading and stress. And then I kind of want to also look up the kinetic chain, so just not at the exact area of pain where this is occurring. So one prospective study did show that those who developed MTSS had weaker hip abductors and tighter IT bands. So kind of like how we talked about with IT band syndrome, where the big problem was overactive TFLs and then weak glute medius, that might potentially be a problem for developing shin splints or MTSS as well. And the reason for that being how we talked about that weak glute max and med, and then added that with the overactive TFL, that just ends up leading to hip internal rotation, then dynamic knee valgus, which then dynamic knee valgus can also lead to ankle eversion and or pronation, which those two we saw were just prospective risk factors for developing MTSS. So kind of just showing that that could be a potential issue as well. Some other potential causes that I know authors suggest, but it just really hasn't been studied or identified completely yet. Sudden increases in intensity and length in exercise. So the whole point is basically you're not strong enough to bear these exercises, and so you're exceeding bone resorption over formation or repair, again leading to tibial stress. However, I will say, this is probably indirect and just me kind of like theorizing though, that one prospective, this actually, if you see number 6, this actually was from the meta-analysis, that inexperienced runners were found to be at a higher risk. So you could potentially argue that those who were inexperienced, maybe when they didn't develop the strength yet within their tibia, and they increased their intensity and length at way too high of a degree, and then that led to the medial tibial stress syndrome. But again, that would have to be specifically looked at. This is just me kind of making some inferences off of previous data and not direct data. Another one, running on uneven or hard surfaces, that really hasn't been studied, but I have seen authors make that claim. Again, that would be a kind of a tough one to be a prospective study, because most people who are running, they're trying to probably avoid uneven and extremely hard surfaces, and would be tough to get healthy individuals. It's like really getting past the IRB to tell them to really run on hard surfaces if you think that is what is causing the pain. So you probably have to use some retrospective studies with that. Another thing, too, to also potentially think about, but hasn't been directly studied, is diet. I mean, what we do know with diet, right, is if we have an energy imbalance, mainly what we're talking about here is an energy deficit, right? So we're not eating enough calories than we are burning off. Then that obviously can lead down to some bone health issues. And this is a primarily important thing for females, because like I talked about the female athlete triad. So if we kind of just go over that, what that is again, right? Typically female athletes, right, if they're under eating, as much as they're actually producing in terms of calories. Then they're in a caloric deficit, and then they don't have the energy needed to maintain their menstruation cycle, which then decreases estrogen. And if we have a decrease in estrogen, which is extremely important for bone health in females, then that could potentially lead to osteoporosis. So again, kind of just the whole idea of how diet could potentially play a role in bone health. And again, that most of the research on MTSS is suggesting that this is an injury caused from stress to the bone, being the tibia. And then lastly here, some structural stuff, so foot arch deformities and then uneven leg lengths, which could potentially affect the loading of the tibia. So just a summary of the MTSS causes. The primary movement inefficiencies that cause MTSS are excessive eversion and pronation. Again, that was indicated by some prospective studies. So what are some potential solutions? We can improve the arch, so doing some short foot exercises. Or we could also reduce dynamic knee valgus via strengthening glute max, glute med, and then working on some ankle mobility, because restrictions there could also lead to dynamic knee valgus. However, what are the common treatments used in the literature? And you'll see that they're pretty much not as much as what I pretty much kind of identified earlier. So what are they using? So the common ones we've been talking about: rest, ice, painkillers, orthotics. Important there, right? Rest. We don't want rest to be too long. So again, rest can help just temporarily relieve the pain, right? But then again, sudden increases in intensity is potentially causing that injury. So you want to have a nice gradual increase. So again, these kind of factors, again, the typical ones people might think of to use: temporarily reduce pain, but it's not going to potentially solve the problem, which is inefficiency in our movement patterns. Also, just a bunch of various PT modalities: ultrasound, electrical stim, and then this shockwave therapy. So most of them saw no significant effects, but some potential studies showing this shockwave maybe having some promising results. Then there's stretching and strengthening the calf muscles. So the idea of basically increasing range of motion, increasing the strength of the calves, right? So we can absorb shock better. And then again, another one being adjusting the training program, so reducing intensity or volume, cross training, gradual return to, but again, we want a nice gradual return to what their normal activity levels were. I will say though, so this is just often suggested by researchers and experts when I was reading these papers, but I really could not find any studies showing that it did work. And if anything, more studies showing that it really wasn't that, they weren't effective methods. And then lastly here, surgery, which has variable results, and then that's kind of just reserved for a last resort option, or potentially for those who have a structural problem, right? Because a structural problem needs a structural solution like surgery. So moving on to what I think could be some good rehab or prehab exercises. One thing you'll notice is I don't have any citations for this slide. This is just me trying to apply what I've learned from this class to medial tibial stress syndrome. So if the arch is the problem, then obviously I think working on the short foot exercise would be advantageous. And work on those intrinsic foot muscles to increase that medial longitudinal arch, and then decrease loading to the tibia. If dynamic knee valgus is the problem, then the stuff we talked about before, glute max activation, glute med exercises would work well. And then I also think in an overall program, depending on current range of motion or strength, I think calf stretching and or eccentric loading could be beneficial. So I know previously, the last slide, I talked about how research showed that stretching and strengthening the calf wasn't effective, but I think those were the only exercises they did in the study. So potentially, what if there were issues up and down the chain they weren't addressing, and so you work on those things, right, but there's problems elsewhere, and so then it kind of just shows, oh, well, then that wasn't effective. But I think what we've been talking about, how if you have decreased range of motion within the calves, right, so decreased dorsiflexion ability, that leads to dynamic knee valgus. So I think it's important to have good range of motion there if needed. And then in terms of eccentrically loading, I think that's also going to help with lengthening the muscle, and then as well as helping with shock absorption, especially if you're someone who is a 4-foot striker. And then I also think tibialis anterior strengthening could be important as well too, right? Especially if you were someone who was a heel striker, where that tibialis anterior is eccentrically working a lot. and needed to be strong. So a tibialis anterior exercise that you could do is these are just called tib raises. And so basically, you just on a wall, you could be standing up straight, any type of support. And then on your heels, you're then basically just going to dorsiflex, try and bringing your toes up to your shin, right? And then so the tibialis anterior is one of the primary movements there is dorsiflexion, and so that's why that exercise is good for strengthening the tibialis anterior. And then lastly here, some dietary changes. So if are you in an energy deficit, pretty easy, just increase calories, right? Or maybe do you have a vitamin mineral deficiency that is reducing bone health, then potentially adjusting diet, right? Trying to get more whole foods in to improve that. And then if that doesn't work, obviously just potentially need the supplementation.